We're actually very lucky to have our very own Dr. Nabel speak to us today about the importance of transparency. Dr. Nabel's been our president here since 2010, so almost 3 years now, and she came to us from the NIH's National Heart, Lung, and Blood Institute, where she was the director who oversaw an annual $3 billion research portfolio, which was quite varied. She's internationally renowned and a distinguished scientist when it comes to genetics and cardiovascular disease. And she's authored over 250 publications and is a full professor here at Harvard Medical School. On top of all of this, I can tell you that we're very lucky to have Dr. Nabel as our leader. She's demonstrated an unwavering dedication to quality and safety of our care. Over and over again, Dr. Nabel has repeatedly not only provided the support we need for our efforts, she's given us something even more valuable, I'd argue, and that's her time. In this vein here, she's actually here to talk to us about the importance of transparency in not just healthcare, but at Brigham. So I'd like you to join me in welcoming her, and we'll turn it over to her.
Thank you. Thank you very much. Well, thank you very much, Alan. It's wonderful to see you all today. Welcome. I look forward to spending the next hour with you to talk about something that's really quite important to all of us, and that is safety and transparency. So how many of you are directly involved in patient care? Great. Good number. And I can't see those of you who are watching via the web, but I'm going to presume a number of you. How many of you have ever made a mistake that harmed or had the potential to harm a patient? Majority of folks in the room, no doubt. Well, it's a hard thing to admit, isn't it? The thought of harming a patient that we're caring for is very scary, and it's actually, I think, all of our worst nightmare. And I know because it's happened to me, and I'd like to tell you a story. Shortly after I left the Brigham, I went to the University of Michigan to join the faculty as an interventional cardiologist. And this was the latter part of the 1980s, and some of the new procedures that we were doing at the time were called valvuloplasties. We were actually taking the balloons that we would do for doing a stenting procedure in the coronary arteries, but they were much bigger, and we would actually place them across a heart valve, inflate the balloon, and try to expand or open up the heart valve. It was called valvuloplasty. And it was one day in which I was going to performing a valvuloplasty on the mitral valve of an older woman. She did not want to undergo surgery. She wanted to have this valvuloplasty procedure done. And so we had explained to her the risks, the benefits, informed consent, etc. The procedure was still under development at the time, and the techniques were actually somewhat crude. We would use a pretty big wire that had a pretty sharp edge, and when you inflated the balloon, you couldn't really control how the wire would go back and forth in the left ventricle. To make a long story short, as I was doing the procedure, I inflated the balloon, and the wire punctured the left ventricle. And she immediately began to bleed into her pericardium and began to code. It was a technical error that I made that led to a complication. Although it was a known complication of the procedure, I was shocked. How could this happen to me? The first thing I did was immediately move to stabilize her. With the support team, we got her to the operating room quickly so that the puncture could be oversewn, and she ended up doing well and survive. But after immediately taking control of the situation, I sat back and I recall the next few days actually being in shock and spending a lot of time talking to my husband, who's also a physician, about that, because I really didn't have anybody else, I felt, in my medical center that I could talk to. This was the late 1980s. I had a lot of different emotions at the time. I felt very insecure. My confidence was shaken. I was the only woman who was an attending in the cath lab at the time, and I can assure you there were a lot of men who didn't want me to be there, and this would only give fuel to their fire. I was very concerned about my patient. Would she be okay, and would she survive? If she didn't survive, how would I ever live with it? I was fearful. What would my colleagues think of me? Would my other colleagues in cardiology think less of me? And I felt isolated. As I said, I only felt I could talk to my husband. I didn't feel this was something I could share with my division chief or to my department chair or anyone else at the medical center. So as a physician and as a care provider, I've been in your shoes. I know there's fear about talking about harm. It's not a comfortable topic, but it is important, and that's why I'd like to spend some time with you today addressing it. So I don't know if any of you had a chance to see a Wall Street Journal essay that appeared a few weeks ago about transparency. The headline was, "How to Stop Hospitals from Killing Us." And the subtitle read, "Medical Errors Kill Enough People to Fill 4 Jumbo Jets a Week." I thought that was pretty provocative when I saw it. So why is transparency important? 2 reasons. One, it's the right thing to do. And I think if there's any principle that underlines everything we do in this hospital, it's doing the right thing for our patients and our families. So being honest and truthful about who we are as care providers, our strengths and our weaknesses and our mistakes when we make them, is absolutely the right thing to do. If we failed as an organization to create a culture in which we can be open with one another and talk about our errors or harm, then we fail to improve our delivery of care. And we really fail as an organization. We owe it to our patients, our colleagues, and ourselves to live, to be human, to live and to learn from one another. It also helps us form trusting relationships with the individuals with whom we deliver care. Think how much easier it would have been if I had been able to go to one of my colleagues in the cath lab and talked very openly about what happened and how we could make it better, rather than living in fear of retribution that somehow I was going to get stabbed in the back because I had made this mistake. The second reason why we need to be transparent is for our patients. The third is for ourselves. We can become victimized in this process. If we don't help support one another, create a culture of openness and transparency, and support one another through this. And we need to ensure that we have programs and resources available to help providers cope with making a mistake. We need to take care of one another. Perhaps that was one of the major lessons I learned when I was at Michigan. We didn't have that kind of culture, and I doubt that many institutions had a culture like that at the time. So transparency is so important to me that we began publishing Safety Matters early in my tenure here. Now, you've seen the online publication, and I would encourage you all to take the time to read it every month. We'll have print copies ready for you as you leave today. And it's very gratifying for me to say that we now get about 4,000 views online with each issue. So that says people are interested in this topic. People are seeking information, and there's an openness and a desire to have a much fuller conversation. I firmly believe that by sharing stories of patient harm that occur right here at the Brigham, we can learn from our mistakes, we can continuously improve our systems, and we can demonstrate our commitment to transparency. So it's very important to me to support the publication, and I encourage you to share in that participation and help us to make it better. So one of the stories in Safety Matters, many of them I should say, focus on serious reportable events, or SREs as they're called. In calendar year 2011, we had 22 SREs here at the Brigham. Let me define an SRE for you. So an SRE, according to the National Quality Forum, is one of concern to the public and healthcare professionals. It's identifiable, it's measurable, it's serious, and it's usually preventable. So the categories for our 22 SREs in 2011 were retained foreign objects, surgery on the wrong body part, advanced pressure ulcers acquired after admission, and death or serious disability related to a medication error, labor and delivery, and or a fall. So we have initiated a number of improvements to try to reduce our SREs, and this year, fortunately, we've had fewer. We've had 15 serious reportable events so far to date, and I think we can be proud of that. So another area in which we've been continuously improving is the volume of our safety reports. Our safety reporting is up 800% over the past decade here at the Brigham. You can see that the chart here begins in 2005. That was the first full year that we had our electronic reporting systems. It doesn't mean that we're making more mistakes. It just means that people are recognizing when something isn't working right in our systems, and or people are more comfortable reporting errors. Reporting more frequently is definitely a positive thing, and it helps us improve our systems. So last year we had 8,500 safety reports, and I thank all of you who made those reports. So who should file a safety report? You should if you are involved in an adverse event, if you detect an error in the care or a potential safety issue, even if you're not involved, or if you experience a near miss. That is, a mistake that almost occurred but it was stopped because it never quite reached the patient. I know there are many of you who have filed reports who are a bit frustrated because you feel that you've not received follow-up, and you can imagine 8,500 is a fair number. I want to reassure you, we are working very hard on our processes so that each of you who file a safety report will have some feedback. It's very important for us to hear from one another, and thank you for taking those steps. Now, I think one of the reasons why people hesitate to report an error is that they have no idea what happens after they do the report, and that can feel a little unsettling. It's kind of like you call the gas company, you report a gas leak, and you wait for the gas company to show up, and it doesn't happen. It just doesn't feel right. So let's demystify the process a little bit. When an incident that caused or could have caused harm to a patient occurs, a safety report should be filed right away. This will alert risk management. However, if a patient is harmed, definitely contact risk management right away. And it's probably a good idea to dispel one commonly held myth. Risk managers are our friends, right? And I see many of you from risk management in the audience, and I think right now we should take an opportunity to say thank you to our colleagues for all that they do. So risk management is here to help us, to protect us, to help guide us in the care of our patients, help us understand what went wrong, and identify and implement a system fixes. So remember that risk management will perform a root cause analysis, or an RCA, for sentinel events, major events, an event that has harmed a patient who has the potential to harm a patient. So a root cause analysis brings together everyone who might have been involved in the error or the potential error to help fix a systems issue within 2 weeks of the event. So there's due diligence, there's investigation, there's due diligence that's conducted, and then results are shared with those who can be impacted, and more broadly, if it's something that could affect care across the organization, that information is shared as well. So some of the topics from our root cause analysis have been featured in Safety Matters for educational purposes with the obvious knowledge and consent of those who are involved. So it's important to understand that a root cause analysis investigation is not a disciplinary action. We're not looking into who caused it, We're not trying to point fingers. Our goal is to understand and then fix system errors. Our intent is to learn from one another, to learn from the people who are involved in the event. They will tell us why something may not have gone right, and importantly, they will have ideas about what we can do better the next time. And this is really how we build safe systems across the hospital. So at the Brigham, you know that we're very committed to ensuring that our patients and their families know when something goes wrong. We support prompt, complete, and truthful disclosure of adverse events, as well as counseling to patients and families. This is a policy that was put into place here at the hospital in 2002. And how one responds to an event can impact patient confidence in our healthcare system. So the goal of the policy is to create open, honest, and compassionate discussion of the event with the caregiver, to provide accurate information to the patient, and to maintain the trust of the patient and the family. Risk management can help support you in this endeavor, can offer you guidance, and can help you in disclosing your error to patient and families if the error has reached the patient. Other departments, including our Center for Patients and Families, can also help. We have our Center for Professionalism and Peer Support, led by Dr. Joe Shapiro, that offers 24/7 coaching about disclosure. And I would really encourage you to make sure that you call for help before disclosing an error to a patient, just as you would seek a consultation from another service in the hospital. There really are some established guidelines and principles that can help you in that regard. So there are a lot of resources here to help you in disclosing a mistake, and you're not alone in this very important consideration. Going back to my patient and their family, the patient was stabilized, and at that time I shared with her that we had a complication of the procedure and that she would need surgery to correct it. I immediately shared with the family that there was a complication as well. I explained exactly what the complication was. The family was very appreciative. As the patient recovered from surgery, I maintained my contact with her, even though she was on the cardiac surgery service at the time, and I continued to follow her and be in close touch with the family as she then left the hospital and went back to her community physician. And I kept in touch with her time to time afterwards. As a result, her comment to me was, you did the best you could. And I understand that these things happen, and I appreciate the fact that you were honest and open with me. And so we maintained that good relationship, and there was not anything adverse that came of it. And I think it was experiences like that I had at Michigan that ultimately led Michigan to develop a disclosure policy with respect to medical errors at the institution, which has cut down on the number of malpractice cases considerably, and they know they've been a national leader. So I want you to know that you are not alone in this process. When an error occurs, it can have a devastating impact on the care provider involved. And the patient is the victim of the error, and the care provider is the second victim. But I want to assure you that you will have all resources available to you that we have in place to support you as a care provider during this process. In addition to risk management, as I've just said, we have our Center for Professionalism and Peer Support. We have our Medically Induced Trauma Support Services, or MITSS. We have our Center for Bioethics, as well as our Employee Assistance Program. As I mentioned earlier, our Center for Professionalism and Peer Support offers a network of trained clinicians who are available for peer support 24/7. Anytime you feel distressed and you want to talk to somebody who's been there, and this can really help a lot. Our Center for Bioethics provides support to care providers who are dealing with ethical issues in their practice. Our Employee Assistance Program offers a variety of services intended to support those who have experienced a critical incident or adverse medical event. So it's really, really important for us to reach out to support and to help one another when an error occurs. I know firsthand that making an error can be devastating, so I really do urge you to reach out, seek help, and more importantly, help your colleagues and peers. Don't allow yourself to become a second victim, and don't allow your colleague to become a second victim as well. Do any of you know who this person is? She's not a Brigham employee. This individual is Kim Hyatt. Kim was a pediatric ICU nurse at Seattle Children's Hospital. 2 years ago, Kim accidentally overdosed a fragile baby with about 10 times too much calcium chloride, and the baby died 5 days later. The investigation revealed that this was the first medical error that Kim had made in her 24 years of service as a nurse. And while the investigation could not definitively conclude that the death was caused by the overdose, the baby was very critically ill in the cardiac ICU. Unfortunately, Kim was fired. And 7 months later, Kim took her own life. Now, we certainly don't have all the facts in the case, and we're not here to judge the actions taken by Seattle Children's. But I can tell you that I would be absolutely devastated if this ever happened here at the Brigham, the Faulkner, or any of our sites. And so I'm asking you to make a commitment with me. This is a commitment I certainly will make to you, and I ask that you make it to me and to one another that we will never allow something like this to happen at the Brigham. You have my pledge that you will never be alone, that you will always have the support to work through what happens after an error is made, and together we will foster what we call a just culture. So what is a just culture? Lucien Leap once said, "The single greatest impediment to error prevention in the medical industry is that we punish people for making mistakes." And we want to remove that impediment. After all, we're all human. We are all going to make a mistake. I remember being a medical intern here in the Brigham in the early 1980s, and one of the surgical attendings saying to my surgical intern colleagues, "Well, if you've not had a complication, you simply haven't done enough procedures." And I think that that's true for all of us in the medical arena, in the healthcare arena. So let's talk about what a just culture is. Can anybody define what to you is a just culture? Any ideas? I've put some ideas up here. Anything to add? Well, people receive constructive feedback after mistakes, that we conduct fact-based assessments and respect the complexity of a situation. We provide fair-minded treatment and encourage staff to speak up about problems. And we use this knowledge to help the organization learn from errors. Now, a just culture doesn't mean that we're not accountable. When an employee is determined to be, and I hate to use the word, incompetent for the role that they're in, or if they've behaved recklessly, or if they're negligent with malice, there should be consequences, just in our own families. As we hold our kids accountable for their behavior, we have to be held accountable as well. And I mentioned at the onset that we conduct about 20 to 25 root cause analysis each year around a variety of circumstances. It's possible that in the process could reveal that an employee, and I hate to use the word, but I will, isn't competent to do their job, or that their actions in this event are not a one-time mistake, or that there's a history of negligence or bad intention. When this is discovered, there are consequences, and we we do owe that to our patients and our staff. I know of only one instance of an employee being terminated as a result of a serious reportable event, and I can assure you that this was not something that was done lightly or done to assign blame. Our intention is never to assign blame. It's only to ensure that our patients are safe and they receive counseling, coaching they need, and that we all learn from the errors to achieve our excellence. So we do want to achieve and strive for a just culture, but we're not quite there yet. And I'm committed to us getting there, and I hope all of you will work with me to get there as well. So let's talk a little bit more about some of the models within a just culture. The model helps us identify the behaviors that could lead to harm and dictates how we can manage them. And they can go from human error, in which we console, to at-risk behavior, in which we provide coaching, to frank, reckless behavior, in which discipline might be required. So let's see some examples of each of these, and you're going to find these a bit light and humorous, and they're intended to help you sort of think through the example. So the first one is on human error, and if we could roll the video. So this is this from Grey's Anatomy? Maybe Nurse Jackie. Like Nurse Jackie Somerville? Oh, okay. So this is meant to be lighthearted, but clearly it's an example of human error where there was a needle stick, where the EMT obviously didn't intend to do it, but it was an inadvertent action. And you can see the response of the managers and the leadership in this case was now to pay attention and to console the individual. So it means speaking with the individual about the processes, in this case, proper handling of needles and syringes, et cetera, and what are the right policies to follow, and providing some education and some training, and then also looking to see if there were any systems errors that might have led to this human error. So the next is an at-risk behavior. This one's actually a little more subtle, so pay attention.
Dr. Hunt, bed 7 is admitted for observation, bed 5 is discharged. I put in a drain in bed 9, and I'm reporting for further instruction.
Organized.
And focused and efficient.
Okay, well, Mr. Aranda here needs to go up to bronchoscopy.
Well, I'll take him.
Oh, actually, no. Proper protocol is to page Dr. Altman. She will schedule the bronchoscopy. See, it's right here on the checklist. Protocol. Okay, so the next step is the OR checklist.
Mr. Aranda, let's get you up to bronchoscopy.
Dr. Yang, 1 minute, please.
I'll be back.
You falsified his checklist.
I streamlined it, and I found a tree in his...
You never paged Dr. Altman. You just hijacked this patient.
So Grey's Anatomy, yes. And two characters who we've grown to like over the years, so it's kind of hard to be completely analytical. But here was an example where Christina's decision not to follow protocol could have jeopardized and put the patient undergoing bronchoscopy at risk. And so how or why she made that decision, whether it looked to be a personality dispute with her colleague, and so she maybe decide I'm going to circumvent the system and I'm just going to automatically check off our checklist, that is at-risk behavior, and that's something that could put a patient at risk. So in this case, our response would be one of coaching, removing the incentives for the behavior, creating incentives for healthy behavior, and educating why this decision was wrong. In their case, probably bringing the two of them together and figuring out why they can't work together in a way that jeopardizes the patient. So the last example allows us to take a look at reckless behavior, and I think this one is a little bit easier to understand.
Izzy. His heart's barely beating. We need to call code. I can't feel a pulse. Izzy, we need to call code.
No, I have a plan.
He's crashing. I need to call the
No,
code.
if we call a code, they will rush him to surgery and replace his LVAD, and then he will stabilize. He needs to get worse if he's gonna get this heart.
Izzy, this is crazy.
He has to get this heart. He will die waiting for another chance. You know he will.
We have to call a code.
No! You press that code button, I will hurt you. Not a lot, because we're friends, but enough so that things will break. And you lie on the floor out of my way. You have a decision to make. You can stay here and help me with this, or you can go. What's it gonna be, George?
So that's pretty dramatic. And I don't know if you caught it in the beginning, but what Izzy did is she snipped or she cut the lines to the LVAD. So she essentially stopped the electrical circuitry coming into the LVAD, which caused the patient to code. And the intent behind this supposedly is that she is so attached to her patient, and she really wants her patient to get a transplant, that she figured if he gets this sick, he codes, it'll get him closer to a transplant. So on the surface, she might have been doing what she thought was right to take care of her patient, but obviously this was reckless behavior that clearly put the patient's life in jeopardy. So in this case, this is where disciplinary and remedial action would be required, as there's really no way that our organization or any organization could tolerate this kind of behavior. So in review then, the just culture model encompasses approaches to human error, at-risk behavior, and reckless behavior. And our intent, again, is never to lay blame. It's only to ensure that patients are safe and that staff receive the coaching they need so that we can all learn from our errors. But it doesn't mean that we aren't accountable for our actions. And that's, I think, the important point here. And, you know, going back again to the example with my patient, again, it's the fact of ownership of what was done that's important. And ownership, as you know, is important in doing the right thing. So we've talked about some of the ways that we are discussing errors across the organization, and we're learning about them and from one another internally. We also are committed to being transparent with the public about our safety record. So data now is available on our website, brighamandwomens.org, for all kinds of outcomes and measures, including our SREs. Information is also available to the public through the Joint Commission and organizations like Leapfrog. Going forward, healthcare organizations will be expected to be even more open and transparent with the public. So this is something that we're doing certainly for ourselves internally, but we also need to be conscious of the fact that the public will expect us to be open and transparent. As of October 1st, the Department of Public Health here in Massachusetts now requires us to report 29 different types of serious reportable events that have been defined for the most part as preventable. And the top three are falls with injury, pressure ulcers, and medication errors. And many more types of medication errors need to be reported. So risk management has laminated sheets to pass out at the end of the presentation about the new reporting requirements, so you'll have access to them as well. So what do we need from you? We need honesty and transparency. As Janet Barnes often says, if you see something, say something. Is that right, Janet? Right. So the slogan was developed by the U.S. Homeland Security, but it's quite appropriate for patient safety. And we count on you to tell us when something isn't right. File a safety report via our BWH safety reporting system. Help us identify problems related to patient care and then help us work the systems so that we can improve the care to our patients and families. And most importantly, be supportive of one another. When something goes wrong, know that we are all in the same boat. It will happen to all of us over the course of our careers, and we're here to support and help one another. Please know that I am personally committed to helping you and ensuring that the hospital has systems in place to help you as well. So finally, I also hope that, as Alan said, that you will take our patient safety culture survey. Everyone who is involved in direct patient care will receive this via email beginning October 22nd. Please take the survey. It's the only way that we can learn from one another and make this a much better place for our patients. So it's been my pleasure to visit with you today on a topic that's really important to me. It's personal in many ways. I know it's personal to all of you in this audience as well. And I look forward to any questions or comments that you might have, not only today in response to the presentation, but to our safety matters and our transparency policy in general. And I certainly look forward to us working together in this area in the months and years to come. So thank you, and I think we have some time for questions or comments. Good.
This is from the web.
Great.
This is from Gina in Infection Control, and she asks, would you consider hand hygiene noncompliance reckless behavior within the just culture definition?
So to repeat the question, would you consider hand hygiene reckless behavior? You know, that's really, really interesting, isn't it? So let's think this through together. We know how important hand hygiene is to prevent the spread of infection from one patient to another. And we also know that we have been incentivized many ways through signs, posters, encouragement, Purell being readily available. I would say that if we fail to engage in hand hygiene, I would hope that for the vast majority, it's not through malintent, but rather that we simply haven't paid attention. And I would probably put it more in the at-risk behavior category, so that we might coach one another and say, gee, I just saw you go into the room and you forgot to Purell after exiting and re-entering. Just a reminder. And that's coaching, and I think that's something we would all accept gladly. Reckless behavior would be, I'm not going to engage in hand hygiene because I want to harm a patient. That would clearly be reckless behavior. That would be cause for disciplinary action. So that's how I would differentiate it, and I would say that for the vast, vast, vast majority of it, it would be at-risk behavior. Would any of you think differently about it? Alan?
So actually, I don't think differently. I agree. I think that.
Why don't you step up? Yeah.
I think that hand hygiene and a lot of the other things that we're asked to do every day can fall into this great category. We all tend to know what the rules are, yet we get very busy throughout the day, and sometimes we forget to do what we're supposed to do. And I think hand hygiene often falls in that category because we are trying to go see 15 patients or get onto our next task, and sometimes we either forget or just think that it's not that important. And I think in those cases it is at-risk behavior. Where it starts to border on reckless behavior is when somebody's either been repeatedly warned to wash their hands and say, I'm still not going to do it. I think that's when you move into the reckless category. So I completely agree.
Yeah.
I'm just wondering sort of where we stand among our peers in terms of this embrace of transparency. That clearly there's been an increase in safety reporting over the years, and does, sort of where do we fall along in terms of the curve of where others hospitals are?
Yeah. Well, I think we are. I would see we're in the group, in the leadership group nationwide, that's ahead of the curve. Some of you, Alan, you may have more information about where we are exactly. What I think is that we've had this policy in place since 2002, that we've implemented a number of policies and procedures here within the hospital. We know that within Massachusetts, there have been some grants recently to initiate programs in other hospitals that are very similar to what we have done. We have received a number of awards. We continue to receive awards each year for our quality safety measures. So I would say we must be in the leadership group nationwide, but if that leadership group is the top 10, 20, or 30% of hospitals, maybe, Ellen, you can provide more detail.
Yeah, so as Dr. Nabel, can everyone hear me? It feels a little loud here. I'll stand up too. When it comes to our transparency efforts, Laura, as you're asking, I think that a lot of institutions have seen an explosion in safety reporting just as we have. So I think we're right out there with everybody else. And exactly as Dr. Nabel pointed out, people don't think it's because care has gotten less safe. It's just that we're doing a better job at detecting it. And everyone's starting to understand that if they see something, they should say something about it. So I think in that regard, we're right there with all the other leaders. I think where we've really started to kind of push the envelope with Dr. Nabel's support, frankly, is our storytelling. If you look around at other institutions, they're not doing this and putting it on the web like we are and having their presidents come and talk about how important this is. So I think in that regard, we're actually out in front of our institutions. We've looked, we did a survey before we did this. Others sometimes put data out there, but they sometimes put it out only to their managers, but no one's telling stories like we are. And we're also going to try to start putting more data on our screens so that folks can see what our performance scores are in key metrics. That's another thing that's going to put us even further out in front.
Mm-hmm. One question that sometimes comes up is we are a teaching hospital. So at the bedside or in the OR or in the emergency room, we will be caring for a patient in the presence of someone who's learning. And what is our role and responsibility with respect to disclosing that to the patient? I think it's a question that we often get. And I would love to hear your thoughts about that. My general approach has been, and I recall specifically doing this when I was an interventional cardiologist, I always brought the residents or fellows who would be assisting in the procedure or taking the lead in the procedure to the patient's bedside ahead of time, so that the patient had an opportunity to meet the fellow or the resident. And I would say, Mrs. Jones, I would like you to meet Dr. Smith and Dr. Johnson. They will be assisting me in this procedure. They are fellows and residents, which means they are here learning, and they have participated in procedures of other patients like yourself, and I would like you to get to know them and ask any questions that you might have ahead of time. That way you've disclosed, as the attending, you've disclosed to the patient that this is a teaching situation as well. And I found that when you're open and transparent in that way, first of all, you give the patient an opportunity to say, well, no, I don't want to have a fellow or resident involved in my case. But more than likely, that kind of openness or transparency, person will say, that's fine, it's important that we teach young doctors of the next generation. And I think people realize that when they come to a teaching hospital, they know that the Brigham is a teaching hospital, there is the expectation that one of their care providers will be someone in training. I don't know, have any of you dealt with the teaching situation differently or have different ideas or approaches about it? Alan, have anything, or Chuck, have anything come up pretty standard? Yeah.
So, Dr. Nabel, in my world of patient and family relations, we are the people that generally are called when patients or their families feel that they don't want a resident or they don't want a fellow. And just as you're saying, you were spot on in preventing even that from happening by disclosing first, this is my team. These are the people that work with me every day. So when you normalize the situation like that, it really enables the patient and his or her family to be able to understand each of the roles and where the roles start and stop, and they can talk to you about it beforehand. And patients love when that happens. Mm-hmm. It makes a complete difference in their demeanor and in their understanding. Even if they hear the term, this is a teaching hospital, they don't grasp it entirely all the time. Mm-hmm. So when you do something like that, you enable that patient to get in the dialogue beforehand, and that's really the key piece.
Mm-hmm. Good. Thank you for the comment. Chuck?
You know, I'm I'm a little bit selfish talking about this here, but I think simulation really fits into every one of these each aspect of what you just said. It's very important in prevention, and we were just up in your suite doing a mock code so that we could identify safety and care issues prior to them actually being a real issue. Mm-hmm. I think we should be more involved with root cause analyses and, you know, sort of going and seeing what we could have done based on, you know, our performance in a simulator, and there are many institutions that are doing this type of thing. Mm-hmm. And clearly in remediation, I think simulation has a place to contribute to this. So being a little bit selfish, and but I want to get the word out there that we are available at Stratus. Great. That if you have issues related to process or safety, we would love to be able to be involved in helping you deal with that using simulation.
Terrific. Thank you. Yes.
So I actually have a background in managing critical incident reporting for a behavioral health organization. And one of the things that I think is really key is making sure people understand how to write a good safety report. People don't understand how to tell the story in a really thorough way that protects them and the organization and leads to being able to do those important root cause analyses. So I think when you're thinking about sort of the training piece, that's an important element as well.
And how could we get more information on how to fill out a safety report?
So I'm Janet Barnes from Risk Management, and there are some safety reporting guidelines that we have on our administrative policy manual on the web. And we do talk about documentation and really trying to be as objective as possible when we're telling a story, just being very factual about it, not drawing conclusions or making assumptions about how something might have happened, because that's really what we're trying to get at when we do a root cause analysis. And my team is somewhat experienced in helping to facilitate that. Obviously, we're not going to tell the story. You're going to tell the story. But at the end of the day, what we really want is the facts of the case and what we can do to hopefully correct it and prevent it from happening in the future. But you're right, and we have tried to provide some guidance around how to write a good report.
Good. Thanks, Janet.
We have time for one more question. If not, that's okay too.
Any last question or comment? If not, thank you all very much, and I'll look forward to continuing the conversation.